At this time, I would like to turn the microphone over to Dr. Proxima to begin the course.
Welcome. We have a great program for you tonight. It's wonderful to see many old friends on the list, and looking forward to tonight's events. This is going to be part one of our nerve series, and we're going to continue to do a couple more sessions on different parts of the nerve. So we appreciate you joining us. The format is that we're going to do the lectures, and then we're going to have some time at the end of the discussion for questions and discussion. It's my distinct pleasure and honor to introduce Steve Green, my friend and mentor. Steve is Associate Clinical Professor and Associate Chief of the Hand Service here at NYU Hospital for Joint Disease and NYU Langone Health. And he's going to talk to us about nerve compression and general principles, and then we're going to get into specifics with each of our other speakers. Steve, if you're ready, we're ready to start.
Thank you, Nader. The aim of my presentation is to provide a foundation for the understanding of the pathophysiology of nerve compression syndromes and the methods of evaluation. Before I go much further, I think it's important for us to spend a bit of time talking about the functional anatomy of the peripheral nerve. I think we're all acquainted with the structure of a peripheral nerve in terms of the epineurium, the perineurium, the endoneurium, and the axons. But one portion of the anatomy which usually doesn't get much attention are the blood vessels which provide nutrition for the peripheral nerve. In addition to vascularity, conduction of electrical impulses requires intact myelin for those large fibers which provide most of our sensibility and motor function. In addition to having intact myelin, the integrity of the axon is critically important for neurological function. It's also very important for us to have a firm understanding of the anatomy of the forearm, wrist, and hand, because nerve compression syndromes predictably occur where nerves pass through fibromuscular osseous tunnels. It's also important to understand that these tunnels vary in terms of their volume based upon the position of joints. This little picture you see on the side demonstrates what happens to the cubital tunnel in positions of both extension as well as flexion. And you can see that in position of flexion, the cubital tunnel actually narrows, which can produce a compression. Also, it's important to understand that nerves glide when they cross joints. If there's fibrotic changes around the nerve which inhibits gliding, this can aggravate or cause a neuropathy. So what are the kinds of effects that compression syndromes produce that we note when patients complain and what we evaluate? And the two things that we critically need to evaluate are the alteration in sensibility and the alteration in strength. As far as the pathophysiology of compression, the amount of compression significantly affects the ability of nerves to conduct electrical impulses. Normally, the pressure within the carpal canal is only 2.5 millimeters. With increased pressure, the ability of these nerve fibers to conduct electrical impulses significantly reduces, and experimentally, when the pressure reaches 60 millimeters, there's complete sensory block. So obviously, the effect of nerve compression is going to be based upon not only the magnitude, but also the duration of compression. The fibers that are mostly affected in nerve compression syndromes are those which are surrounded by myelin. And as you know, myelin helps produce a significant increase in conduction velocity compared to axons which are not surrounded by myelin. So any compression which destroys or damages the myelin is going to significantly affect the ability of the axons to conduct electrical impulses. I think we should separate the effects of compression into two basic categories. One is a neuropraxia. This tends to be a physiological effect on the nerve in terms of its ability to conduct electrical impulses. This is frequently reversible. It is frequently associated with loss of myelin, but what's very important to understand is that the axons are intact. These are patients who present with paresthesias and some weakness. An axonectomesis is a much more serious effect of compression, and in this situation, the axons are actually disrupted. These patients, rather than complaining of paresthesias, have true numbness, and these patients, rather than having weakness, have visible atrophy. I like to separate the symptoms of compression into three stages. The earliest stages is episodic paresthesias, which means that the patient may have episodes of the neuropathy, but there are other times when the nerve function is completely normal. An intermediate stage is when the symptoms are sensory, are constant, and they have mild weakness, whereas in the late stage, the patient has constant numbness as well as severe weakness. I think this is a worthwhile checklist that you should use in evaluating patients who have a suspected compression syndrome. Obviously, we need to look at whether or not there are other underlying problems such as diabetes or arthritis, which may affect nerve function, and sometimes, unfortunately, neuropathies such as diabetes and compression can coexist. As far as physical examination is concerned, I think the first thing we are always taught in medical school is to look. And what we should be looking for is swelling and obvious atrophy, as you see here, of the thenar muscles. Joint mobility needs to be tested because some patients have arthritis, which will significantly affect the mobility of their joints. And sensory and motor function and provocative testing is something I'm not going to talk about. As far as sensibility testing is concerned, I think we need to be somewhat objective. These two tests are not purely objective, but I think it's important to record sensibility testing so that when you reevaluate the patient, you can compare whether or not there has been progression or resolution of the problem. Two-point discrimination is most easily performed. However, it's only abnormal when the disease is severe. Sims-Weinstein testing, which tests threshold rather than density, detects much earlier compression, but it takes much more time to perform this, but it is certainly more accurate in determining early compression compared to two-point discrimination. I think it's critically important to do muscle testing and to grade the muscle based upon this famous English method because, again, we want to determine whether or not there has been progression or resolution of the problem both before and after any form of treatment. There are a number of provocative tests, which I'm sure all my co-speakers will discuss. These provocative tests, I think, are useful for a patient who has episodic symptoms, especially in a situation where the patient presents without symptoms in the examining room, but you can reproduce the symptoms either by percussing over the nerve, which we call a tunnel, or by narrowing the canal, as we're doing here on the right, by putting the wrist into extension and compressing the carpal canal ligament. Electrodiagnostic studies are very useful. They are objective. However, they are not perfect. They tend to be effective in determining whether or not there's slowing of conduction. When we look at these electrodiagnostic studies, I think it's important for all of us to read the studies rather than to just look at the determination made by the person who did the study. We look for slowing of conduction, and we look for reduction in amplitude of response. As far as the EMG portion, this is critical in determining whether or not there's any evidence of axonal loss, where you see evidence of fibrillations or positive sharp waves. In the absence of fibrillations and positive sharp waves, this probably presents as a neuropractic lesion rather than as an axonotomesis. The problem, however, with electrodiagnostic studies is that they're not always accurate in determining what is going on clinically. These are very useful studies, but I think we need to rely on history, physical examination, usually as equal to electrodiagnostic studies. The other problem with electrodiagnostic studies is it really depends upon the skill of the person doing the study, and I would recommend that each of us find someone that we can rely on to do these studies. Otherwise, we get inaccurate findings. To give you some examples of the negative aspects of these studies, there was a study done in the Journal of Hand Surgery of patients who had clinical evidence of median nerve compression syndrome in the forearm, but only 24% of those patients had electrodiagnostic evidence of this problem. In measuring the carpal canal, 10% negative and 10% false positive have been consistently found. Ultrasound has now become a popular way of objectively determining the diameter of the nerve. It does not necessarily determine function of the nerve or the severity of the compression, but it certainly is very accurate in determining the level of compression at whether it's the cubital tunnel or, let's say, the carpal tunnel. MRIs are rarely useful in nerve compression syndromes, but certainly useful if you think that there is a tumor which is causing the problem. So now I'm going to turn the lecture series over to my friends who are going to talk about the typical syndromes affecting both the median, ulnar, and radial nerves. Thank you.
Thanks, Steve. That was great. Appreciate it. So now that we've had an introduction to some of the concepts, we're going to talk about the specifics of the nerve, and it's a great pleasure and honor to introduce David Tuckman. David's a great friend, awesome surgeon, and always gives fantastic talks, so I've been looking forward to learning all about the management of median nerve compression. David, when you're ready, please go ahead.
Great. Can you guys see my slide?
Yes.
Good. All right. So I'm going to talk about management of median nerve compression. I just want to say, it really is an honor for me to talk, have you on a panel with my hand surgical mentors and heroes. So definitely appreciate the invitation. So let's jump in. So I'm going to talk about both carpal tunnel as well as pronator syndrome. So carpal tunnel is really the most common compressive neuropathy of the upper extremity. Incidence about 1 to 3 cases per 1,000 per year. Prevalence about 50 cases per 1,000 per year. With an economic burden of $2 billion in 1995 money, you can imagine what that is today. Risk factors, probably one of the most common is diabetes. And you have hypothyroid, rheumatoid and other inflammatory conditions, obesity, pregnancy, age, and female gender. And what is not on this list is repetitive use of a keyboard. I don't think that carpal tunnel syndrome is caused by repetitive use, no matter what you can Google and speak to everyone, but I do think that carpal tunnel can be exacerbated by. For anyone knows Steve Green, I would ask him to tell you the story about how that actually started. It's actually a very interesting story. As Steve said, spoke about doing nerve tests. I think it's important that not all patients need nerve tests. Carpal tunnel really is a clinical diagnosis. We make the diagnosis on exam. Nerve tests, the problem is that they are really very operator dependent. And as Steve said, a negative test doesn't mean that someone, doesn't have carpal tunnel. But, the nerve test can be normal in 8 to 20% of patients with clinically and surgically proven carpal tunnel. And as well, they really don't correlate with outcome. As Steve said as well, ultrasound is actually becoming more, more popular and is kind of being studied more. And if you look at the change of the median nerve cross-sectional area, it does correlate with severity of carpal tunnel. And there's studies to show that a change in cross-sectional area of 2 millimeters above the carpal tunnel and within had a 98% sensitivity for picking up carpal tunnel. Has obviously the advantages, it's much cheaper, as well as any time you can not stick needles into someone and zap them, I think they'll be much, much more comfortable. Does have the disadvantage of all of the other, issues with ultrasound is it really is very operator dependent. Or non-operative treatment, splinting does work and it is effective in patients that have carpal tunnel for a short period of time, typically less than 3 months. Injections of cortisone are an option. 80% have short-term relief. 22% are symptom-free at 12 months. For me, I use injections of cortisone when the exam is equivocal. Do they have cervical radiculopathy and carpal tunnel? Do they have diabetic neuropathy and a compressive component as well? Giving injection of cortisone will give you a very good prediction of how they're going to respond to surgery. If they don't get a good response from the injection, they're probably not going to get a really very good result from surgery. I do use cortisone actually in women who are pregnant, typically in their third trimester, and they're absolutely miserable. You can give injection of cortisone. You can hold them off until they deliver, and then the carpal tunnel typically goes away. Medications, nothing works. Nothing's really been proven to be beneficial. B6, gabapentin, NSAIDs, unfortunately, nothing works. I think it is worth a short discussion about acute carpal tunnel syndrome, which is related to trauma, typically distal radius fractures and carpal dislocations, case reports of acute carpal tunnel from hematoma blocks. You can get acute carpal tunnel from wrist position, kind of post distal radius fracture reduction and casting if the wrist is placed in extreme flexion or extension, which you definitely do want to avoid. I think so. If we would look at the presentation, so you have the patient that falls, they injure their wrist, and instantly their hand is numb. That is a traction neuropathy. That is not an acute carpal tunnel. Typically, the acute carpal tunnel patient comes in with a normal exam, and then slowly that nerve starts going out. You have a progressive, you have a progression of the exam as well as they have pain. Whether it's emergent or urgent, you have to do it in the middle of the night or the next day. There is good data to say that you can wait until the next day with basically equivalent results. That being said, I would probably take them the same night. I probably don't want to sit on an acute carpal tunnel. Really our kind of big concern when you're talking about carpal tunnel surgery is the thenar motor branch variance. And if you look at the Lance classification, you have group 0, which is basically kind of the typical textbook anatomy where the motor branch, branches right after carpal tunneling, and it goes straight radial. It would be great if every patient had this. Unfortunately, there are a significant number of variants, and really the variants are what keep us up at night in terms of not injuring the nerve. And there are variants of the thenar branch itself. There's accessory thenar branches. There are high divisions of the median nerve. There are proximal accessory branches, and a lot of these are kind of interesting if you're doing an anatomic study. But if you're actually talking about carpal tunnel surgery, there are a couple that actually you really have to know, and you really have to be very, very careful about. And it's really these four, and it's really the conjoint where the motor branch branches early, goes through transverse carpal ligament, and then rejoins. The ulnar word, that actually the nerve branches and goes off from the ulnar side of the nerve, then comes superficial, and then innervates the muscles, and then there's a supraligamentous, and then what is not in the Lance classification is the pre. Now, And I think the key is you just have to be very careful. You don't really want to be very aggressive. You want to make sure you take your time, and you want to always be looking for these variants because not everyone is a normal thenar motor branch. And I think that's really very, very important. Like this was my case. You can see that this is most likely an ulnar word where the nerve comes off ulnar, comes superficial, and really the key is you have to identify this. You have to obviously protect the nerve, and just the key is just being very careful. So obviously there's always a big debate. You want to do this, open? Do you want to do it endoscopic? We do know that there is an earlier return to work with endoscopic. There are recent studies show there's really no difference in complication rate between the two. And the results of the two are really, pretty much equivalent after about 3 months. Just kind of from my own experience, I've been in practice for about 15 years. My first 7 years in practice, I did these all open, and then I transitioned to endoscopic. And I'd say the big difference that I've seen is that, when I was doing them open, I would see the patient back at about 10 days, and I'd say, look, if you're fine, you don't have to come back. You can go back doing anything you want to do. 10 to 20% of those would bounce back and see me at about 6 to 8 weeks later, and just with a complaint of just being sore. And obviously, reassure them you're going to be fine, it's going to get better. When I switch to endoscopic, the bounce back rate is almost zero. Now, they all end up at the same place, but I think the endoscopics just get there faster. You do have the option when you're talking about doing an endoscopic release. You can do either a mobile cannula or you can do a stationary cannula. This video shows, and hopefully it plays, the video shows a mobile cannula. And I do have concerns with this in that you're basically bringing the whole cannula in and out. And I have concerns that, you can have a nerve that can kind of pop in and you won't notice and you can cut it with the blade. I personally prefer using a stationary cannula. This is a dual portal system. It has one portal as a viewing portal. One is a working portal. Most important thing is that the cannula stays where it is. Procedure done under local sedation. There's always a nice wrist crease which you can use. You can hide the incision. And you want to be careful. You don't want to kind of pound through the skin. You want to just come through skin, spread straight down to to the volar forearm fascia. And you can see it kind of has these transverse fibers. Then you want to do the proximal release. I always do the proximal release first, and then come through the volar forearm fascia. As soon as you see fat, then you know you're done. And then release proximally, and you don't really have to go very far, maybe half an inch, and then you want to start releasing distal, and you want to kind of free and release the median nerve from the undersurface of transverse carpal ligament. You want to release, pretty far distal, because as soon as you extend the wrist, the incision does tend to kind of translate a little bit distally. So you want to use roll towel, extend the wrist about 45 degrees. All systems are basically the same. They have, they basically have progressive dilators. You want to kind of stay ulnar. You kind of hit the hook of the hamate, and that kind of brings you in. Then there's a rasp that kind of just cleans up the undersurface, and you want to start basically midline, and then you want to go ulnar. You don't want to go radial. Cannula then goes in, and then the camera goes in, and you can see you really get a great view. You do want to take a very good look. Make sure that you don't have a nerve sitting there. You want to make sure there's no tenosynovium on top. And it's very important. So my right hand is only doing tilt and is not pulling. I am pushing actually with my left hand. My left index finger is pushing. And it's very important. You want to use your intrinsic muscles of your hand have much more fine motor control than your arm muscles pulling. Full thickness cut, about 75% of the length, and then you go back as many times as it takes to complete it. And usually twice is enough. and then you want to bring that proximally. As soon as you see fat coming down, you know that you're through. And then you complete it, and camera goes back in. So you see those longitudinal fibers. Those are fibers of the palmar fascia. You know that you're complete. Little band there. Just go back in, complete that, and then you're done. And I close this with intra-buried sub-Q fibromonocryls, Dermabond, and a Steri-Strip. It really does give an amazing cosmetic result. That incision basically will disappear after about 6 months. So my post-op, I do the same post-op for carpal tunnel, triggers, decurvains, mucus cysts. I stopped giving narcotics about 3 years ago. I just give a leave, 2 tabs twice a day, Tylenol. They can mix in Tylenol between or at the same time. We know that splinting and casting for carpal tunnel is not only not necessary, it is actually can be detrimental. Therapy for post-op carpal tunnel, definitely not necessary. So let's go to pronator syndrome. Pronator syndrome is a compressive neuropathy of the median nerve at the elbow. I don't think pronator syndrome is a very good name for it because while pronator is the most common, it is not the only site of compression. The signs, you typically have these kind of vague aching pain in the proximal forearm. You do get paresthesias as well in the median nerve distribution, pain with activity. There are 2 different presentations. You can have more of a chronic presentation. You can also have patients that have an acute presentation, young, involved in sports, weightlifting, and they tend to have a more acute presentation with significantly more pain. If you look at our sites of compression from proximal to distal, you always, with every one of these patients, you do want to get an x-ray of the elbow. You're looking for a supracondylar process, which is basically a bony protuberance off the distal medial aspect of the humerus, and you get basically a ligament of Struthers, which is a fibrous band that goes from the supracondylar process to the medial epicondyle. The median nerve will go below, and the brachial artery can go either above or below. And I think it is very important to remember that you can get a ligament of Struthers without a supracondylar process. So having a negative X-ray does not mean that is not a potential site of compression. Next, if you go distal, look at Lacertus. Lacertus is a fibrous band that goes from the distal biceps, kind of fans out medially over the flexor pronator mass, and the median nerve goes under this. You can get compression of the median nerve with the form as the form goes into pronation. It draws Lacertus kind of distal and deep. There is an interesting study, Journal of Shoulder Elbow, 7 young patients with an acute flexing injury. They had severe anterior proximal forearm pain, and the Lacertus was a primary compressive source. Pronator, there are 2 heads of pronator, superficial and deep. The median nerve will typically go between those 2 heads, but there are some variants of that as well. It is the most common site of compression, and you do get these, kind of thickened intramuscular bands within pronator that can be the site of compression. Then the last site of compression is this kind of fibrous arch of the flexor digitorum superficialis that can put pressure on the nerve as well. On exam, you get a Tinel's, but only 50% of patients have a Tinel's. You want a Tinel's over the proximal extended proximal run of the median nerve. There's a compression maneuver, kind of like a Durkin's of the wrist, in which you put pressure over the median nerve, about 4 centimeters medial, 4 and 6 centimeters distal to the medial epicondyle. You can kind of also do a similar thing where you kind of use all 4 fingers and go over the entire course of the nerve. Motor exam, typically normal. And then I think really the question, and a question I would actually like to ask the panel as well to comment on afterwards is, can we pinpoint our site of compression and tailor our surgical release based on our physical exam, and specifically provocative maneuvers. So you can look at pronator syndrome. You can look at pronator as a site of compression with the elbow in extension with resisted forearm pronation, looking for reproduction of paresthesias. FDS, resisted PIP joint flexion of the middle finger. You can look at Lacertus with the elbow flexed at about 100 degrees with resisted forearm pronation. Our diagnosis is really purely clinical. It's based basically on our physical exam. Nerve tests, not really reliable. Vast majority are normal. You do want to differentiate it from carpal tunnel syndrome, and whenever you think of carpal tunnel syndrome, always think about pronator as well. If they've kind of any pain in the forearm, you always want to examine for pronator. Treatment, activity modification. If they're doing a specific activity that bothers them, obviously they should avoid that specific activity. Anti-inflammatories, maybe. Pronator stretching, FDS stretching, maybe. Corticosteroids, a big maybe. 50 to 70% improve by themselves, kind of eventually. And if not, then obviously we talk about doing a decompression, and we have two options. We can actually have more than two options. So we can do a complete, where you basically releasing all four sites of compression with good texture results, 71 to 93%, or we can do a limited release. We're just releasing those specific sites that we are specifically concerned about. With really, based on the current data, very similar results. There are just descriptions of an endoscopically assisted release where you make a small incision and use a scope. And the pictures are very interesting. I personally do have concerns about using an endoscope for this because we're not doing a lot of this, a lot of these cases. And to get on the right side of the learning curve, I think you're going to take you a very long time to get there, if ever. I personally prefer to make a little bit of a larger incision and just make sure you're safe. I personally would do a kind of like a hybrid between the two, do more of a mini open, go between pronator and FCR. I kind of release as far distal as possible. You do ideally want to release the FDS as well, but again, questions about tailoring your release based on your exam. And you just want to, anything that's putting pressure on the nerve, you want to take that pressure off the nerve. Thank you.
All right, David, thank you. That was a great talk, as always. While we're loading up Dr. Posner's talk, I just wanted to say I usually go big on the pronator release.
Yeah, you know what? I have concerns about going small because you know what? The problem is that if someone doesn't do well, and you do a small incision, or they do well just because it's a different diagnosis, or did they not do well because, well, actually they did have a ligament of Struthers that was actually the source of compression, and doing a small incision, you aren't releasing it. So, yeah, I definitely agree with that.
All right, fantastic. Thank you. Our next speaker needs no introduction, Dr. Martin Posner, clinical professor of orthopedic surgery, and he's the chief of the hand surgery service at NYU Langone Orthopedic Hospital. And he's been the chief. This is going on to his 50th year, so we're congratulating him and very excited to hear his talk. The ulnar nerve compression is a classic talk full of pearls. So every time I've heard it, I learned new things, and we're very excited to welcome Martin to the talk. Martin, please go ahead and start when you're ready.
Thanks, Nader. I hope you all can hear me. Is that correct?
Yes, perfect.
Okay. So I'm going to talk about anatomy and pathophysiology of ulnar nerve compressions at the elbow and at the wrist. Mention whether regarding treatment if surgery is always necessary, and when surgery is necessary, what procedure to use, and I'll give you some surgical tips. So the sites of ulnar nerve compression at the elbow, there are 5 sites. And the first begins at the arcade of Struthers, and we learned what the ligament of Struthers is, but this is the arcade. It's the longest site, and it begins at that area and extends to medial epicondyle, a distance between 6 and 10 centimeters, and the arcade consists of fibers from the medial head of the triceps. It's an interesting anatomical variation.
And Dr. Posner, it seems we may have lost your audio. Your phone may have been muted.
Can you hear me now?
Yes, I can. We are hearing just a slight echo, so if you
Maybe
might be able...
I'll mute my computer. Can you hear me now?
Yes, that would be perfect.
Okay, thank you. So the common causes of compression at this first site involve the medial head of the triceps, which can be quite hypertrophied in bodybuilders where the muscle snaps over the nerve. And it's also seen as a postoperative complication from ulnar nerve compressions and transpositions where the medial intermuscular septum was not excised, and now the nerve is gliding over that sharp edge. Site number 2 is at the medial epicondyle, secondary to cubitus valgus deformities from malunited supracondylar fractures. It was first described by Mouchet in 1914 in France, and was commonly referred to as the maladie de Mouchet. 2 years later, Hunt gave it the name that still persists today in this country, which is tardy ulnar nerve palsy. The third site is the epicondylar groove, which has bone both anterior and lateral, involving the epicondyle and olecranon. And laterally, there's also the ulnar humeral ligament, and posterior is a very thick and dense fibroaponeurotic covering. This site has the greatest number of causes because there can be lesions within the groove, such as a fracture fragment or synovitis or infection. There can be lesions outside the groove, as seen in individuals who lean on their elbows for many hours each day, like long-distance truck drivers. And in red, I put poor positioning of the arm during surgery. This has sometimes been a cause of medical malpractice suits. And I have to say that I've successfully defended several of these. And in each of these patients who had a total joint replacement, the claim was that the anesthesiologist incorrectly positioned the arm during surgery and they had an ulnar nerve compression. And every one of these patients had problems preoperatively. So that's very rarely a problem. There are some patients who have hypermobile nerves due to laxity of the fibroaponeurotic covering. I've never seen a tear of the covering, although it's been mentioned where it could be hypoplasia of the trochlear. There's a difference between a hypermobile and a subluxated nerve. About 20% of us have hypermobile nerves, which are vulnerable to compression when a cast or a splint is applied with the elbow flex if the nerve is running over the epicondyle. It's also vulnerable to injury when injecting a medial epicondylitis, but there it's very easy to make sure that before you're sticking a needle into the epicondyle, the ulnar nerve is not in the vicinity. Very often, people with hypermobile nerves require surgery for them. Site number 4 is where the nerve enters the flexor carpi ulnaris muscle. And this is the true cubital tunnel. The roof of it is a fibrous band, which has been referred to as the triangular ligament, the arcuate ligament, or Osborne's ligament. Fidel and Stratford in 1958 used the term cubital tunnel. And cubital tunnel syndrome refers to compression at this specific site. If it's not at that site, ulnar nerve compression at the elbow is the more accurate description. And my words are aimed mainly at our residents and fellows because I think as experts, it's important to use terminology accurately and appropriately. So when people say they have cubital tunnel syndrome, it refers to compression at this one site. This site is very vulnerable to compression with elbow flexion, as Steve Green pointed out, because the cross-sectional area changes from an oval to a flattened ellipse as the medial collateral ligament bulges somewhat, but more importantly, the Osborne's ligament becomes taut. And here's two clinical examples. On the left, the elbow is extended and the probe is under a very lax arcuate ligament. And on the right side, the elbow is flexed, and you can see this sharp band that becomes very taut. With elbow flexion, pressure on the nerve increases sevenfold. And if you add into that contraction of the flexor carpi ulnaris muscle, the pressure increases 3 times that, almost to 20 times. And that's an important number to remember when I discuss in a few minutes treatment. Another factor to be considered is the fascicular pattern within the ulnar nerve at the elbow. The fascicles provide tensile strength. The greater number of fascicles, the greater tensile strength of a nerve. And since the fascicles are surrounded by perineurium, the perineurium is the key fibrous structure of nerves that resist stretch. And normally, the number of fascicles in a nerve increases when a nerve crosses a joint. And that's intuitively makes sense because the nerve is under tension at those points. However, there are exceptions. There are some nerves in the body who are vulnerable to stretch injuries because rather than the fascicles increasing in number, they decrease. And one of those nerves is the ulnar nerve at the elbow. That for some reason, when the nerve crosses the elbow, the number of fascicles decrease. And it's been said that the problem with humans is that they did well and never had ulnar nerve compressions until they assumed an upright position. That when we were walking on all fours, we didn't have ulnar nerve problems. And the other exceptions in the body is the axillary nerve at the shoulder and the peroneal nerve at the knee, both nerves that also are susceptible to stretch problems. Site number 5 is where the ulnar nerve leaves the flexor carpi ulnaris. It penetrates the fascia between the superficial and deep muscles, flexor muscles. Peter Amadio referred to this as the flexor pro.
I apologize for the technical problems. Dr. Posner is back, and we can get started again.
Okay, so I started to talk about the muscles that usually the intrinsic muscles are first affected more than the extrinsics. And when it's the extrinsics, it's usually the profundus to the little finger. The FCU is rarely affected. There are probably more eponyms associated with ulnar nerve weakness and paralysis than any other orthopedic or hand condition. And I'll just draw attention to a few of them. Frohman's sign, referred to as the paper sign or the sign de journal, was how it's pictured in this picture. Rather than grabbing a piece of paper between the thumb and fingertips, a fist is made, and the piece of paper is grabbed between both thumbs that are adducted. That's the way Frohman did his sign. The Wartenberg sign is important because I believe it's the only eponymous sign that is often a presenting symptom by the patients. I've had several patients come to me with the only complaint was that they noticed they could no longer adduct their little finger. So that's an important sign, the Wartenberg, because it can be the only presenting symptom of the patient. I mentioned the Mumenthaler sign only in fun because I love to ask residents and fellows, what's the name of the sign where you get paralysis of the palmaris brevis, which is totally unimportant, that unimportant muscle is paralyzed, and the only thing that it does is that you lose the ability to wrinkle your hypothenar eminence. Steve Green did a lovely discussion about electrodiagnostic studies, and we've all seen cases of a clinical evidence of ulnar nerve compression at the elbow. Patient had all the signs and symptoms, and yet the electrodiagnostic studies were negative. And why is that? And one reason is that when measuring conduction studies of the ulnar nerve at the elbow has to be in a flexed position. And the next time you have a patient who you're pretty certain has an ulnar nerve compression at the elbow, and yet the electrodiagnostic studies are negative, ask them the position that their elbow was in when the examiner tested the conduction times. And almost invariably, they'll tell you that it was in an extended position. Regarding treatment, if there's no muscle weakness, there is no urgency for surgery. And if you can reverse the irritation of the ulnar nerve at the elbow, very often the symptoms will disappear. And the easiest way to do that is avoid pressure on the elbow, avoid keeping the elbows flexed for long periods of time, so no reading in bed. And patients can use an elbow splint for sleeping, or they could use an athletic elbow pad, where instead of the pad over the olecranon, they spin it around 180 degrees, so it's resting the antecubital fossa. Now, I mentioned before the effect of the flexor carpi ulnaris on ulnar nerve compression in the cubital tunnel. And I treat patients who have severe symptoms but no muscle weakness in a long arm splint. Although it's a little unwieldy to wear, I use a long arm splint because I want to also eliminate the effect of contraction of the FCU, which, as I said earlier, increases pressure on the nerve 20 times. So patients are advised to wear the splint for about a month. They can remove it when washing or bathing, and they can also remove it several times daily to exercise their elbow so that it doesn't get stiff. There are two basic operative techniques for ulnar nerve compression of the elbow. There are decompressions without transposition, which include decompressions in situ and medial epicondylectomies, and then there are decompressions with transposition, which include subcutaneous, intramuscular, and submuscular. Now, decompressions without transposition, someone is working my slides without me touching it. Decompression without transposition was first described by someone with the unlikely name of Farquhar Buzzard in 1922. It was referred to as a simple decompression, and it is very simple. The original indication was a decompression of the ulnar nerve either proximal to or distal to the epicondyle, and not opening up the fibroaponeurotic covering over the epicondyle. And there were two types. Here's an example of a distal in situ decompression that I did in a concert violinist who only had symptoms after she played the violin for a few hours, and she had compression at the true cubital tunnel. Here's an example of a proximal in situ decompression, which was done in a bodybuilder who had a massive hypertrophy of the medial head of the triceps that was snapping over the ulnar nerve. Now, there's been a recent popularity in simple decompressions for the past few years, and it's often recommended for patients who have no muscle weakness because it's a simple operation, and usually the surgeon incises the fibroaponeurotic covering over the epicondyle. The risk of that is that it can cause subluxation of the nerve out of the groove, and what they recommend is at the time of surgery, if that happens, then do a transposition of the nerve. But again, if there's no muscle weakness, there's no urgency for surgery, and very often, if you treat this non-operatively, the symptoms will subside. Medial epicondylectomies were described by King and Morgan, and the idea is that it eliminates the prominence against which the nerve is compressed. The disadvantage is that it doesn't eliminate traction forces on the nerve that occur with elbow flexion, and there's always a risk of taking too much of the epicondyle or too little of the epicondyle. And this is a procedure that's rarely performed, and personally, I've never seen it performed. Decompressions with transposition, the main advantages are that the nerve is repositioned to a less scarred bed, and that, more importantly, tension on the nerve is relieved with elbow flexion rather than increasing. It's also used in obese and elderly patients with elbow arthritis, and subcutaneous transpositions are the most common type. And as I said, it's used in conjunction with surgery for other problems and used in obese and elderly patients. The disadvantage is that the nerve is vulnerable to additional trauma, especially in thin, active patients. And a technical tip when doing a subcutaneous transposition, in that in making the fascial sling, instead of basing it medially at the epicondyle, base it laterally so that the nerve is against the smooth surface of the fascia when that fascia is sutured to the subcutaneous tissues rather than the rough surface underneath. Intramuscular transpositions were first described by Adson and then 10 years later by Platt, who actually recommended that the nerve be inserted in what he referred to as an intramuscular gutter. The nerve would be placed over the flexor pronator muscle mass, And exactly where that nerve glided over that part of the muscle, a deep cut would be made in the muscle and the nerve stuck inside the muscle. Obviously, that really made the nerve very prone to action forces on the nerve because you could see that the muscle scars to the nerve and causes traction on it. I think this has to be one of the dumbest operations. I don't think it's ever indicated. Submuscular transpositions were described by Learmonth in 1942. The advantages are that it releases all potential sites of compression, and the nerve is protected by a thick muscle mass at the end, the flexor pronator muscle, and it's an effective operation when other techniques, such as a subcutaneous transposition, are not effective. It's my preference in young, active patients with a thin layer of subcutaneous tissue. So this is an operation that should be done with a tourniquet. It doesn't have to be a sterile tourniquet because a regular tourniquet won't interfere with proper draping. And the objectives are that you want to visualize all possible areas of compression. So this is a fairly long incision. And the other objective is at the end of the operation, you want the ulnar nerve to run in a straight line from as far proximal in the operative area as possible to the most distal part. And the incision begins over the medial intermuscular septum, which is very easy to palpate in the upper arm. And it continues along the epicondylar groove midway between the olecranon and the medial epicondyle. And it continues into the forearm over the ulnar nerve, which is also easy to palpate. It's important to identify, protect, and mobilize the olecranon branches of the medial antebrachiocutaneous nerve that are always in that area. The medial intermuscular septum is identified and excised. I usually leave a little bit of it at near its insertion to help suture the flexor pronator muscle to the most proximal part of it. And then the fibroaponeurotic covering of the epicondylar groove is incised. And finally, Osborne's ligament is incised over the cubital tunnel. I think it's important, since ulnar nerves that are being operated on are quite irritated, that I avoid retracting them with either instruments or tapes. And I think it's much safer that if you have to retract it, use your finger, because you have immediate feedback that you're not putting any tension on the nerve. And where the nerve is compressed, I'll always do an epineurolysis. When detaching the flexor pronator muscle group, do not start at the epicondyle. First, start at the proximal edge of the pronator teres. The reason being is that if you do that, you'll immediately identify the brachialis muscle. If you start at the epicondyle and start elevating the flexor pronator muscle group from that area, it's not too difficult to find yourself deep to the brachialis muscle. I did that once, and it never happened again when I realized that I first want to identify that muscle. So first detach the flexor pronator group proximally. When you detach the flexor pronator group, do it with a fibrous cuff of tissue. It's far preferable than cutting through the muscle in a step-cut fashion. And when doing this, you have to use a scalpel. You don't want to use a periosteal elevator to try to push it off the epicondyle. Identifying the medial collateral ligament, which is just distal to the epicondyle, is not difficult. And I always tell the fellows that your dissection here, you don't even really have to know the names of the structures, just operate by color. The muscle is obviously red, the ligament is white, and if you use a scalpel, you can peel off the muscle off the ligament in a very easy fashion. The entire flexor pronator muscle group should be detached, and if you note the course of the ulnar nerve, it's in a relatively straight position, and just further to the lateral aspect, you always see the median nerve as well. And you want to relieve any fascial bands. And don't assume that small branches are articular branches that can be sacrificed willy-nilly. It's not difficult to preserve these small branches because sometimes they're branches to the muscle. There was once an article written about this that emphasized this point. And you could mobilize these branches by interfascicular dissection. He was someone who had a prior, what was referred to in the opera report as a submuscular transposition, and who had a lot of problems postoperatively. And obviously the nerve was put deep to only a portion of the flexor pronator muscle. So essentially this was an intramuscular transposition, which I said earlier should never be done. And the problem was this nerve was really irritated to the point that there was actually bone around the nerve. When reattaching the flexor pronator muscle, fixation to the bone is very secure. And depending on the size of the epicondyle, I'll make either 4 or 6 drill holes, and those drill holes accommodate 2 to 3 mattress sutures of a 0-grade braided material, and the knots are tied behind the epicondyle, so they're not palpable in any way. And the fixation in this manner to bone is very secure, and at surgery, you could easily fully extend the elbow, and there's no risk of the muscle detaching. I always will resuture the proximal edge of the pronator teres, and that's why I'll usually retain a little part of the distal part of the medial intermuscular septum, and I resuture the proximal edge there, and I'll then close the fibroaponeurotic covering over the epicondylar groove, which further protects the knots of the sutures, which are never palpable. And then the patient is put in a dorsal splint with the elbow in about 30 to 35 degrees of flexion, the forearm and wrist in neutral, and the splint is used for 3 to 4 weeks. Postoperatively, patients regain full range of motion of their elbow. It's not necessary to immobilize the elbows in more flexion than 30 or 35 degrees. A few words about ulnar nerve compression at the wrist, or ulnar tunnel syndrome. The anatomy is described by Guillaume, who happened to be a urologist. It's about 4 centimeters in length, and zone 1 is from the level of the pisiform to where the nerve bifurcates into motor and sensory divisions. Compression at this site it involves both the sensory and motor deficits of the ulnar nerve, and all of the ulnar innervated intrinsics are affected. Zone 2 affects only the motor division, and there are only motor deficits, involves all the intrinsics except the hypothenar muscles, which are innervated in zone 1. And zone 3 is the sensory division, where you're going to get sensory deficits in the ulnar nerve distribution bolally. There are a number of causes for ulnar nerve compression. Most of them are in zone 1. It can be due to use of crutches or canes, and a variety of masses. The most common are ganglia. It can be synovial chondromatosis, a hemangioma, or in the lower left-hand corner, an ulnar artery thrombosis. You can have arthritis in the piezotracheal joint, causing irritation of the ulnar nerve. And an excellent operation for this is to excise the pisiform. And by splitting the FCU at its insertion on the pisiform and peeling it off it, it's very easy to repair that muscle so you don't lose any of its function. Sometimes there are anatomical abnormalities, including fascial bands, that cause it. And you can be trauma, fractured pisiform or fracture hook of the hamate. And just a couple of words of fracture hook of the hamate. Alex Norman, who was a radiologist at the Hospital of Joint Diseases many years ago, coined the term eye sign. That if you look at a PA view on the left of a wrist, you'll see a circular density, which is he referred to as an eye, EYE, not the letter I. And a hook of the hamate, if you don't see that eye side, it usually indicates a fracture, but it's at the base of the hook. If the fracture is not at the base, but through the body of the hook, as in these x-rays, in this CT, you will still see the eye sign. With respect to surgical decompression of the ulnar tunnel, I have just 2 tips. An incision along the radial margin of the hypothenar eminence is best, and then curve that proximally into the wrist crease. And if you have to go further proximally, go up the longitudinal surface of the distal forearm. Avoid incisions on the hypothenar eminence itself, because it's a contact area for grasp. And if you're decompressing both the ulnar nerve, at the same time you're decompressing the median nerve in the carpal tunnel, always decompress the ulnar nerve first, because the intact transverse carpal ligament facilitates exposing the ulnar nerve. Thank you very much.
Martin, thank you very much for that great talk, and I'm so sorry about all the technical delays. Thank you for getting through them. We're back on, and our next speaker is Dr. Stephen Glickel. Dr. Glickel is a clinical professor of orthopedic surgery here at NYU Langone Health, and Dr. Glickel, one of the former presidents of the American Society of Surgery of the Hand. We were very lucky to have him join our faculty a few years ago and combine our fellowships, and we're that much the better for it. Steve, if you're ready, please go ahead.
Okay, so I'm going to talk about radial nerve compression. Sorry. Okay, so this was a iteration of the talk which left out a couple of slides, but basically we're going to talk about anatomy, radial tunnel syndrome, posterior interosseous nerve syndrome, and Wartenberg syndrome. So to briefly review radial nerve anatomy, in the upper arm, the radial nerve is posterior to the humerus and courses distally to the spiral groove. It penetrates the lateral intermuscular septum, and then it enters the anterior compartment approximately 10 centimeters proximal to the lateral epicondyle. In the brachium, it lies in the interval between the brachioradialis laterally and the brachialis medially, and it innervates the brachioradialis and the ECRL. It then divides into the superficial radial nerve and the posterior interosseous nerve, which course distally anterior to the radiocapitellar joint and lateral to the biceps tendon. The superficial radial nerve runs anteriorly and distally beneath the brachioradialis, and then the PIN proceeds distally and deep and medial to the ECRB. At the level of the radial neck, there's the leash of the recurrent radial artery, or the leash of Henry, which crosses the PIN and can be a source of compression. The PIN then goes deep to the superficial head of the supinator, beginning at the arcata froge. So the arcata froge is the fibrous proximal margin of the superficial head of the supinator. So in this dissected specimen, you can see the posterior interosseous nerve beneath the superficial head of the supinator, which has been divided here. And then the PIN passes distally from anterior to posterior in the interval between the superficial and deep heads of the supinator. It emerges distally and divides into branches innervating the superficial extensors. Sorry. So there are several sites of possible compression of the posterior interosseous nerve. The fibrous bands anterior to the radial head at the entrance of the radial tunnel, the radial recurrent vessels of the leash of Henry, the tendinous origin of the ECRB, the arcata froge, the proximal margin of the supinator, which is the most common site of compression, and then the distal edge of the supinator. So Jepson and Engber pointed out that it's possible to have more than one site of compression. So you can have a double entrapment at the proximal and distal supinator borders. So you need to explore the nerve throughout its course in the radial tunnel to achieve decompression. So radial tunnel syndrome is a compressive neuropathy of the posterior interosseous nerve in the proximal forearm, causing pain but no motor deficit. Interestingly, though, the posterior interosseous nerve palsy is a compressive neuropathy of the posterior interosseous nerve in the proximal forearm, causing a motor deficit but no pain. So the same nerve is compressed in two different syndromes. So to give you a historical perspective, Rolls and Maudsley in 1972 described what they called resistant tennis elbow in 38 elbows. They related this to repeated pronation, supination, and elbow extension. And on exam, the patients had pain with resisted long finger extension, with the elbow extended, and tenderness over the radial nerve in the proximal forearm. All of these patients responded to decompression, 33 of them through an anterior muscle splitting approach. And then Lister, Belsol, and Kleinert a few years later described 20 elbows. The clinical signs they described were pain with long finger extension, tenderness over the radial nerve in the proximal forearm, pain with resisted supination with the elbow extended, and they decompressed the nerve using a posterior brachioradialis splitting approach, and 19 out of the 20 patients had relief of symptoms. So the most common presentation of radial tunnel syndrome is that it is more common in the dominant arm, occurs in the 4th to 6th decade. Men and women are equally affected. It tends to have an insidious onset, and the cause is usually repetitive microtrauma rather than an episode of acute trauma. And 5% of patients who initially present with tennis elbow actually may have radial tunnel syndrome. So the etiology is felt to be repetitive activities involving forearm rotation and elbow extension with or without wrist flexion. In some patients, there's a dynamic component to the compression, and it also may be related to hypertrophy of the supinator muscle in laborers and athletes. So the typical symptoms are pain on the lateral aspect of the elbow and proximal forearm. Pain may radiate distally more than proximally, and pain is aching in character, and we'll get back to why that's important. The pain is also exacerbated by activity and usually relieved by rest, but it sometimes occurs at rest as well. It's also exacerbated by lifting objects with the wrist flexed and the forearm pronated. Night pain is common, and there may be weakness of grip, which is secondary to pain, not due to denervation. The clinical signs are tenderness over the supinator from the proximal to the distal end. So that's distal to the lateral epicondyle and the proximal forearm. And importantly, there's absence of tenderness of the lateral epicondyle unless there is coexistent lateral epicondylitis. The clinical signs are also pain with resisted extension of the long finger with the elbow extended, and pain with resisted forearm supination with the elbow extended. And the reason you extend the elbow is to eliminate the contribution of the biceps to supination. One of the ways you can help to diagnose radial tunnel syndrome is to do a diagnostic nerve block using local anesthetic. So if you inject local anesthetic just proximal to the radial tunnel, in the interval between the brachioradialis and brachialis, you should eliminate the symptoms. And one of the ways that you know you're in the right place is you often get an associated transient motor block. So the principal differential diagnosis of radial tunnel syndrome is lateral epicondylitis. And the principal way to distinguish between radial tunnel and lateral epicondylitis is the location of tenderness, i.e., there is not generally tenderness of the lateral epicondyle if the pain is from radial tunnel syndrome, and the converse is the case. The other ways, and I mentioned this previously, is the character of the pain. So the character of the pain in radial tunnel tends to be dull, whereas the character of the pain in lateral epicondylitis tends to be sharp. And it's also, one of the things that can help you distinguish is the response to injection, be it in the radial tunnel or near the radial tunnel or the lateral epicondyle. Electrodiagnostic studies are generally not useful in radial tunnel syndrome. Occasionally there may be EMG changes, i.e. denervation, particularly with resisted contraction of the supinator, and generally the nerve conduction studies are negative. In less than 10% of patients, you have positive EMG and nerve conduction studies, according to this published article. And so negative studies do not at all rule out a diagnosis of radial tunnel syndrome. So the question arises, how can a pure motor nerve cause pain? And Lister, Dulsol, and Kleiner proposed that the PIN carries sensory afferent fibers from the radiocarpal, intercarpal, and carpal metacarpal joints, and also carries afferent fibers from the muscles that it serves, and this may be the source of pain. So conservative treatment includes rest, long-arm splinting, anti-inflammatories, avoidance of provocative activities, therapy with extensive stretching and ultrasound, and steroid injection. If conservative treatment fails, the nerve needs to be decompressed, and there are 4 approaches that have been described. One is the anterior or modified Henry approach. Then there's the posterior Henry or Thompson approach, posterior approach through the brachioradialis ECR interval, and the transmuscular brachioradialis splitting approach, and we'll go through these briefly. So in the anterior approach, the incision is a curvilinear incision beginning approximately 6 centimeters proximal to the lateral epicondyle and 3 centimeters medial to the lateral supracondylar ridge. It extends distally between the biceps and brachioradialis. Then it crosses the antecubital fossa from lateral to medial, and it extends along the medial border of the mobile wad, and then curves laterally toward the ulnar border of the brachioradialis. So the cephalic vein and lateral antebrachial cutaneous nerve need to be identified and protected. The fascia is incised along the brachioradialis. The brachioradialis is retracted laterally, and the biceps and pronator are retracted medially, exposing the nerve. So proximally, as I mentioned before, the radial nerve is between the brachialis and the brachioradialis, and as it enters the forearm, there's a fibrous band over the PIN at the fibrous edge of the ECRB above the probe, which needs to be divided. The radial recurrent vessels are ligated. The arcade of Froge is exposed and incised longitudinally, and then you incise the superficial head of the supinator completely, exposing the compressed part of the posterior interosseous nerve. This is just another incision to the anterior approach, a slightly simpler incision, and you can see the decompressed nerve and the hyperemic markings on the surface of the nerve. So the first posterior approach is through the ECR-EDC interval, and it's easiest to identify that interval distally and then work proximally. So your incision starts distally and then extends proximally toward the lateral epicondyle. The forearm fascia is incised longitudinally. The interval between the ECRB and EDC is developed distally and dissected proximally, and then the supranator lies deep to the dissected muscles proximally. You identify the fibrous edge of the ECRB. These vascular clips are on the radiant recurrent vessels, which have been ligated. The arcade of Froge is incised, and the superficial head of the supranator is incised. Another approach is through the brachioradialis ECR interval. It's a 6 centimeter longitudinal incision beginning just proximal to the radial head and 3 centimeters lateral to the biceps tendon. You develop the interval between the brachioradialis and the ECRL. The PIN is identified, and the remainder of the procedure is the same as the other posterior approach. And then finally, the approach which I prefer is the transmuscular brachioradialis splitting approach, which can be done through a longitudinal or transverse incision. Longitudinal incision starts just proximal to the radial head and 3 centimeters lateral to the biceps tendon. The transverse incision is about 4 centimeters long over the mobile wad, just distal to the radial head. So the fascia of the brachioradialis is incised, and the fibers of the muscle are split longitudinally for about 5 centimeters until the fat deep to the muscle is exposed. And you dissect through the fat, you expose the posterior interosseous nerve, and the rest of the procedure is the same. These authors described a series of 49 elbows in 42 patients. There were 14 excellent, 18 good, but 8 fair and 9 poor results. 3/4 of the patients were improved after surgery, but 1/4 obviously weren't. 1/3 of the patients had persistent functional limitation, and 75% of the poor results were in workers' compensation patients. Jepson and Engbert reported 33 elbows using the brachioradialis splitting approach. They had 67% good or excellent results, and 1/3 fair or poor results. And their comment was that the results of this study suggest that complete pain relief and return to activities after radial tunnel surgery is not as predictable as previous studies have indicated. And then Dean Saturianos decompressed 28 elbows to an anterior approach. He had 39% good or excellent results, and the remainder were fair or poor, and a significant percentage of the poor results were in workers' compensation patients. Posterior interosseous nerve syndrome is compression of the PIN, which innervates the ECRB, the supinator, ECU, EDC, EDQ, APL, EPL, EPB, and EIP. And generally, the causes of PIN compression can be a mass, either a lipoma or a ganglion. You can have elbow synovitis and rheumatoid arthritis, which puts pressure on the nerve, or repetitive activity, particularly involving pronation and supination. So there is no pain in the PIN syndrome, and the symptoms can either be a complete PIN palsy or partial PIN palsy. So in a complete palsy, you have loss of finger MP extension, loss of thumb extension and abduction, and you retain wrist extension radial deviation because the ECU is out and the ECRL is in, causing the radial deviation. Now, you can have a partial PIN palsy of any component of the PIN, and it may be specific to the medial branch, which is to the ECU, EDQ, and EDC, or the lateral branch, which supplies APL, EPB, EPL, and EIP. So the diagnosis is primarily made on physical examination and confirmed on EMG nerve conduction studies, which are usually positive in PIN syndrome. And you may need imaging in the form of MRI or ultrasound to rule out a space-occupying lesion. So the differential diagnosis can include cervical radiculopathy, which, however, is usually, it doesn't result in as specific deficit as PIN palsy, Parsonage-Turner syndrome, but the characteristic symptom at the beginning of presentation of Parsonage-Turner is pain, which is not present in PIN palsy, tendon rupture, and one of the ways you can distinguish tendon rupture from PIN palsy is the wrist tenodesis effect. And the other differential is radial sagittal band rupture with subluxation of the EDC, and there you can demonstrate that that's what the pathology is by straightening the finger, bringing the MP joint into extension, and then the patient is able to hold the MP joints extended under their own power. So if imaging shows a mass or a ganglion, early decompression and excision of the mass is indicated. If there is no mass, you want to observe the symptoms, perhaps consider steroid injection, because some of these do resolve. If there is no improvement by 3 months, you generally start thinking about decompression. Now, some authors talk about 3 months, some 6 months, but certainly by 6 months, you'd want to consider decompression. And the approach for decompression is as described for radial tunnel syndrome, the same surgical approaches. So this first series talked about 94% of patients, i.e. 16 of 17 patients, who had full recovery of motor function after decompression of the PIN by a mean of 4.5 months, and surgery was performed at an average of 2.2 months after the onset of symptoms. And the second series reported 75% good to excellent results at a mean of 5 years in 8 patients with PIN decompression at 4.5 months post the onset of symptoms. Now, finally, I'll talk briefly about Wartenberg syndrome, which is compressive neuropathy of the superficial sensory branch of the radial nerve. So the superficial sensory branch of the radial nerve can be compressed anywhere along its course in the forearm, but it's most at risk at the posterior border of the brachioradialis and the interval between the brachioradialis and the ECRL muscles. So in pronation, the ECRL moves closer to the brachioradialis, compressing the superficial branch of the radial nerve between the muscles. And with wrist flexion and ulnar deviation, the nerve is stretched. So activities requiring pronation, wrist flexion, and ulnar deviation apply both a compressive and a shearing force to the nerve. So the symptoms are pain on the dorsoradial aspect of the distal third of the forearm, which radiates to the dorsum of the hand, thumb, index, and middle fingers. Clinical signs include Tinel sign over the superficial branch of the radial nerve in the interval between the brachioradialis and ECRL. And you can distinguish the pain from decurvains by the absence of provocative tests and the lack of relationship to wrist and thumb position. Electrodiagnostic studies may show decreased amplitude of the sensory nerve action potential and prolonged sensory latencies. So many of these resolve spontaneously, so the initial treatment should be observation and may include splinting and steroid injection if the symptoms persist. Surgical decompression includes incising the fascia between the brachioradialis and the ECRL from 6 to 8 centimeters proximal to the point of emergence of the nerve between the muscles, and distally to the insertion of the brachioradialis on the radius. And then you do a neurolysis of the superficial branch of the radial nerve. And this study by Lanzetta and Fouché described 74% success in 23 patients treated for Wartenberg syndrome. Thank you.
Okay, thank you very much, Steve. Next, we're going to have a talk by one of our awesome hand therapists. Kevin, are you ready? Thank you very much. Kevin Chen is one of our hand therapists, and he's going to talk to us about the hand therapy considerations in compressive neuropathies. Please go ahead when you're ready.
Can you guys hear me?
Yes.
Great. Thank you, Dr. Pensima, for the introduction. Again, my name is Kevin Chen. I'm an occupational therapist and CHT at NYU Langone Orthopedic Center. And again, I'll be discussing the role of hand therapy in the management of compressive neuropathy in both the pre- and post-operative patient. So the goals for this lecture is, of course, to explain the evaluation process of hand therapy and to describe the common methods and techniques hand therapists utilize for this population. So let's jump right in. So after the doctor diagnoses the patient and the patient arrives at hand therapy with their referral, we'll go through our own evaluation to assess the patient's current level of capability, which will govern the interventions that we will implement. Strength is, of course, assessed by the Jamar dynamometry and manual muscle testing. Patients are also screened for range of motion deficits, which will be formally measured via goniometry if necessary. Sensation is assessed via 2-point discrimination and Sims-Weinstein monofilament testing. We will also perform a battery of provocative tests and maneuvers. One such maneuver is the upper limb nerve tension test as described by physiotherapist David Butler. And each test will obviously be different depending on which nerve you are assessing. And we'll be discussing this in further detail later. For the postoperative patient, we will, of course, assess the condition of their surgical site and their scar. As therapists, it is, of course, our duty to monitor postoperative wounds for signs of infection and report this back to the referring physician for further evaluation and possible treatment. And lastly, we evaluate the patient's context and environment for areas of opportunity that we can address to set the patient up for success. So let's talk specifics about the median nerve. So again, we will perform a battery of provocative tests such as Phelan's, Snell's, and Durkin's to best understand how the patient is presenting. One of which is the upper limb nerve tension test, and these 6 pictures demonstrate the tension test maneuver for the median nerve. Although you might not have a partner beside you to passively perform this test, I invite you to attempt this series actively while you're at the comfort of your own home. Beginning with position 0 at the top left-hand corner, the subject is passively placed into each position in sequential order. And at each position, the subject is asked if their symptoms are reproduced. Once the provocative position is identified, the test is completed, and these findings dictate and govern our intervention process, where we assign the appropriate nerve glide. Displayed are some examples of glides that we might provide to a patient. Again, the prescribed glide is determined by the findings from the upper limb nerve tension test that we previously discussed. It is important to note that the effectiveness of nerve gliding in general remains to be controversial. Some studies point that the biomechanical behavior of peripheral nerves is not very well understood, which calls for further investigation and research. Despite the lack of statistically significant evidence, nerve gliding can be effective anecdotally, and thus is a helpful tool in the hand therapy toolbox. Custom splinting is also a valuable tool in the realm of hand therapy for the treatment of many diagnoses, including the conservative treatment of mild carpal tunnel syndrome. Pictured here is a volar wrist cock-up splint, which can be worn both full-time or at night to maintain the wrist in a neutral position. By maintaining the wrist in neutral, the risk to inadvertently rest in a provocative position, in essence, the Phelan's or the reverse Phelan's positions, is eliminated. However, in the instance where the compression of the median nerve is a result of lumbrical migration into the carpal tunnel, the traditional wrist support splint will need to be modified. Displayed here is a wrist cock-up with the MPs blocked into slight extension, preventing the MPs from achieving full flexion. Depending on the severity of the case, the MPs may need to be positioned further into extension than what is pictured here. For the postoperative patient, one immediate concern is scarring. While some patients are blessed with genetics that allow them to heal quickly and easily, some might not be so fortunate. As a scar develops, it can become hypertrophic, sensitive, and painful to touch, and the developing scar tissue could also entrap the very nerve that was just decompressed. Strategies in which we as hand therapists utilize to address scarring include manual scar massage and using putty elastomer and silicone gel sheets. Some studies point that after a wound has healed, moisture evaporates more rapidly through scar tissue and can take up to a year before it returns to pre-wound levels. Through the use of hydrating creams and silicone gel sheets, the ability to retain hydration is restored, preventing excessive scar formation. For the sensitive scar, we expose the hypersensitive region with varying textures, building tolerance gradually so that the affected area becomes tolerant to normal daily stimuli. Every patient that comes in with compressive neuropathy is very likely to complain of muscular weakness and how it has detrimentally impacted their lives. It is our responsibility to address these concerns, and to best set our patients up for success, exercises should respect the order of motoric return following a nerve lesion. Strengthening exercises can be as straightforward as dumbbell curls to creative uses of therapy. Depending on the patient's capability, an exercise can be performed with gravity eliminated, or it can be complex with varying elements to hit multiple muscle groups. Displayed here are some examples of strengthening exercises that we employ in hand therapy, especially for muscles affected by median neuropathy. While knowing and understanding the patient is critical in all stages of care, I find that it is especially important here in the strengthening phase. Is the patient the type to be overzealous with their strengthening and do 5 sets of 50? Or perhaps they're the anxious type and benefits from encouragement and positive feedback instead. Either way, knowing and understanding the audience is key to success. So now we'll move on to the ulnar nerve. Again, we would evaluate the patient's status at initial eval with a battery of provocative tests. And again, included in our evaluation is the ulnar nerve tension test. Again, although the test requires a clinician to perform this test passively on the subject, I invite you to perform this test on yourself actively. Once again, with the results from our tension test, we will prescribe the appropriate nerve glide. The concept of nerve gliding dictates that while the subject places tension on the nerve distally, the subject side bends their neck to the ipsilateral side, therefore decreasing tension proximally, which you can see demonstrated in all of these images. With regards to splinting, especially for the ulnar nerve that subluxes, we would provide an elbow extension splint. Shown here is a prefabricated elbow extension splint that we commonly use. By maintaining the elbow in a slightly extended position and preventing symptom-provoking positions, the risk of ulnar nerve compression at the elbow is decreased. In the event of a severe ulnar nerve lesion, an ulnar claw can be observed. In this scenario, the ulnar nerve innervated intrinsics are unable to extend the IP joints of the finger. The MPs of the ring and small finger are positioned in hyperextension because of the imbalance between the properly innervated EDC and also the weakened ulnarly innervated lumbricals. Depending on the level of the lesion, the ulnar heads of the FAP may also be affected. Regardless of the lesion, the ulnar claw deformity results in a significantly non-functional hand. What we can do as hand therapists is to fabricate what is known as an anti-claw splint, which positions the patient's ulnar 2 MPs into a flexed position, correcting the hyperextended deformity and giving the patient an opportunity to function in their daily life. With ulnar neuropathy, exercises can be tailored to strengthen the intrinsics of the hand and, of course, progressing to power grasping. Lastly, we have the radial nerve. Again, we assess for upper limb nerve tension testing and subsequently assign the appropriate nerve glide. Now, this is especially useful for a patient with radial tunnel syndrome. And as we've heard earlier, the radial nerve is vulnerable in many different areas at the so-called radial tunnel, which results in motoric dysfunction as well as a significantly localized pain at the lateral elbow. Nerve glides and wrist extensor stretches may be helpful in treating a patient diagnosed with radial tunnel syndrome, but much less helpful with a patient with radial palsy. In the event of a high-level radial neuropraxia, a patient might experience the inability to actively supinate the forearm, extend the wrist, nor the ability to extend the MPs of the hand. This phenomenon is commonly known as wrist drop. This position is entirely non-functional because as we go about our day, we reach and we grasp with a tenodesis grip, where we grip and grasp while having our wrist in the extended position. In mild cases of this, where it is expected that the nerve function will return quickly, splinting may be an option for this patient. Using and revising the volar wrist cock-up splint we had previously mentioned, we can position the patient with the wrist in a much more extended position, therefore decreasing the tension on the radial nerve as it returns. However, for a much more complicated case of wrist drop, a more imaginative splint is required to maximize the patient's function. In that scenario, we would fabricate a dynamic radial nerve palsy splint. On the left, you'll find two dynamic splints that allow for active digit flexion, which is, of course, unaffected by radial nerve neuropathies. With the use of the outrigger, it passively brings the patient's MPs into extension, allowing for the patient to actively release a grasped object. You may notice that the two splints are dissimilar in that the top one does not include a wrist component, which is included in the lower splint. That is because the lower splint is fabricated for a patient with a higher level nerve compression, where active wrist extension is absent in addition to the absent digit extension. Here you'll see a dorsal and volar view of the low-profile radial nerve palsy splint, which serves as an alternative option for patients who would prefer not to have their splint include an outrigger. And of course, it offers the same purpose as the previously mentioned radial nerve palsy splints. When the radial nerve function returns, it is again important for us to know and understand the order of motoric return for the radial nerve, especially in the case of radial nerve palsy. As we wait for these muscles to regain function, we should aim to preserve passive range of motion of the entire upper extremity. Once capable, strengthening can be in the form of gravity-eliminated positions, progressing to against gravity and finally against resistance. For the patient with radial tunnel syndrome, one should be careful to avoid excessive wrist extension and supination, which may reproduce the very pain that you're trying to avoid. Last but not least, I cannot stress the importance of evaluating and treating the patient with their context in mind. As Dr. Tuckman said, repetition can exacerbate a patient's symptoms. And so we should really ask, how is the patient spending the majority of time in their day? Are they studying for long hours for an exam with their elbow propped up or bent? Do they have a habit of propping their left arm on the car window while they drive? Are they working from home with a less than ideal workstation setup? These are all stories that I've heard from patients who have come in with some form of compressive neuropathy. And I'm sure that you've heard of similar stories as well. So in addition to a clinical assessment, we as hand therapists don our detective hats and take deep dives into the patient's history to evaluate their environments. We then recommend methods for activity modification to best set the patient up for success. Even if not directly causative, their environment is very likely to be correlative to their diagnosis. We would be doing the patient a disservice if we treat without fully understanding their context and not evaluating them from a holistic lens. Thanks for tuning in.
Kevin, thank you very much. I always rely on our hand therapists to make us look better, and you guys always do, and that gave us a great insight into what nerve gliding and nerve tests are all about. So this is the end of our talk. I apologize for our technical issues, but we had some great, fantastic talks, and I did notice some of the questions here. We'll try to answer. With regards to the person who lost a lot of weight, I think that certainly if a nerve becomes more compressible, that's a possibility, but otherwise the weight loss itself doesn't have much to do with it. And Dr. Leibowitz was asking about a complete nerve palsy, which may be related to a more proximal cervical issue or brachial plexopathy. I wanted to thank all of our panelists and everyone for hanging in with us. I see we still have 140 people with us, so appreciate your time. And I'm going to end the meeting here and say thank you very much.